outside, but then again, we are in Florida. Today is May, what is it, 14th? May 14th. And if you're watching, today you're watching live surgery. We stream all of our surgeries from the Deuk Spine Institute Surgery Center Viera live over the internet. Thank you. Yeah, no, I appreciate it. These surgeries are streamed over Facebook, Periscope, and YouTube. Perfect, thank you. All right, Louise, turn. Huh? What about it? I think I'm okay. Yeah, thank you, though. All right, so our patient is under general endotracheal anesthesia. She's asleep. We want her fully relaxed for the surgery, and she's draped. We have the left side of her neck exposed. Needle. And is the table high enough? Needle. Is the table high enough for a lateral view?
Do you have a cap there that all the irrigation is going to go underneath that?
Just not worry about that right now. Shot. So 2, 3, 4, 5, 6. We're down at 6, 7. I want to be a little bit higher. Shot. Again, I want to be a little bit higher. 2, 3, 4, 5, 6, 7. So I'd like to try to get shot. So 2, 3, 4, 5, 6. You agree? AP. It's a quick AP. Make sure our tip is somewhere near the midline. Shot. Good. Lateral. It's perfect. Why is this needle not set properly, Luis? Come on. This cannot be this way. Okay. Look at it. What's the problem here? It's backwards. Luis. Shot. Can you please make sure these things are right, Louise? Shot? I mean, it is a problem. It should never happen. Shot? Need to go up a little bit. Shot? 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 Give me an AP. It's a quick AP. Just get an AP. That looks really good. Lateral. So we're in the midline. And I've got to get my fingers out of here because it's killing my fingers. Quickly, quickly. All right. Shot. Right. Shot. Get those wires out of there, please. Are you paying attention? Shot. AP. Coker. Luis, time to graduate to the big leagues, okay?
Sir?
That means you got to think about everything I'm going to need and have it ready for me. So there's no delay. Okay? Good. No, I'm happy with that. Let's go lateral. Lock it down. Shot. Perfect. I like that. Shot. Pretty collapsed. Okay. You can put those down. All right. I'm going to do a little tender teaching moment for you, okay? Since you need a little help. See these guys? Can't shoot rays through them, okay? On the AP here, are they in the way?
On the AP?
Nope. On the lateral right here, are they in the way? Nope.
No.
They're not. Go ahead and take a shot. See? Magic. Okay? How did I know this? Because I figured it out. Okay? I didn't just keep letting it get in the way, and never solve the problem. It's a problem when it's in the way. Somebody has to solve it. You're going to have to solve problems. Okay. Shot. All right. We're overexposed. Let's do a little better job. Shot. Better. All right. So we got 2, 3, 4, 5, 6. Everybody agree? Santiago? Yes. Go ahead and do an AP. Go ahead, shot. Quick shot. Perfect. Lateral. Thank you. So she's got tears on both sides. We frequently see tears on both sides. It's very common. All right, so don't worry. We'll take care of this with the blue towel later. Get to a lateral shot, please. All right, nice. So guide wires in. I'm going to take the needle out. Take that. I'm going to do some local. Lateral view. Perfect. Loco. We'll make a little incision, but I'm going to numb it up first. Take. So there's epi in there, right?
Yes, sir.
Good. Yeah, anytime we're on the skin, we want to use epi. Good. All right. So I'm very happy with the position of the incision. I'm going to have to make an incision now. The incision is 4 millimeters.
That's a 15. You need an 11. That's what you're thinking right now?
You're exactly right. That's why I'm having trouble. I've never used a 15. It's always an 11. You don't know that?
Yes, sir. I mean, I have a here.
Can you go off the air for a second?
1 second.
And
Do you want to go completely off or just mute?
Are we on?
Yes, sir. We have a question too.
All right, great. We have a question from the audience. So right now I'm bringing the dilator down. I made a small incision on the neck, and I have to bring this dilator through the soft tissues down to the spine. Shot? All right, give me a second and I'll take the question. I just want to make sure this goes right. Shot. Notice the guide wire is not moving. Shot. You always have to worry about the guide wire advancing inadvertently, meaning you don't want it to advance, but it still advances. Our incision is definitely big enough on the skin, so that's not impeding me. Shot. So I'm right against the spine at this point. I can feel the anterior longitudinal ligament, which is the ligament in the front of the spine. I'm actually pretty happy. Shot. I'm pretty happy with my view from the side. The tip of my dilator is right where it's supposed to be. What I'd like to know is where is it on the AP view. So go ahead and do an AP. And let me have a coker, please. Yeah, AP. All right. All right, good. So you can see the tip of the dilator is dead center. That's where I want to be. Go ahead and go back to a lateral. So if you look at the spinous process, it looks like a teardrop in the middle of the spine there. That's actually a piece of bone in the back of the spine, and that's the middle of the spine. So we're right there. And you can be about 3 millimeters to 4 millimeters off, maybe 5 at most. No. So first thing I got to do is get this forward. I'll take the question. Shot.
We have a viewer asking, can spine problems like herniated discs also cause problems with urinating?
All right, so somebody says, can spine problems like a herniated disc also cause problems with urine? Yes, definitely they can. They don't always, and they rarely do, but they can. Shot? For example, a herniated disc in the neck, like the one we're fixing today, if they're big enough, they push on the spinal cord, patients will lose the control of their bladder. Shot? So this patient's herniated discs in the neck are not big enough to cause incontinence. Shot? All right. So I'm seated into the disc at this point. I'm taking my guide wire out because I'm safe. Shot? And she's got a pretty collapsed disc here. Shot? And we're going to get all the way to the back. Shot? Remember, shot, as we're doing this, we're going through that normal disc and kind of spreading it. Kind of like, imagine taking your finger, or a pencil actually is better, even a skinny pencil, and putting that through imagine you have a jar of jelly, okay, that hasn't been used, and it's got a nice smooth surface of the jelly, the jam. And you take this little narrow tip and you push through the jelly and you go all the way down to the bottom of the glass jar. You can see the tip at the bottom, so you've made it all the way to the bottom. And then you take it out. Well, when you take it out, the jelly collapses back around where the tube was, you know, and you can almost not even tell that you had put the tube through the jelly. So that's kind of what the disc is. It's jelly. Okay, that's good. And now I need a 4x4, right, to pound on top of? Good, thank you. Yeah, I'll do that. You just hand it to me. I'll do that. All right. So shot. All right. So that's fine. Can you give me some inline traction? So I'm asking my anesthesiologist to distract the spine a little bit, straight in. That's good. Shot. I want to make absolutely sure the tip of the dilator doesn't advance. Shot. 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 So as I'm bringing the tubular retractor down, shot. Again, I want to make sure that the dilator that it's running along, shot, doesn't go into the spinal cord. Shot. Now without the dilator being there, is that the shot right there? All right, so shot. That's pretty good. Shot, that should be good. Yeah, I'm happy with that. Without the dilator being there, I would just be doing a biopsy of the disc, which I don't want to do. I don't want to take a biopsy of the disc. We're not trying to biopsy anything. Use your guide wire and push that out. I'll take care of that. So you really want to get to the back of the disc before you start removing disc. If you don't have the dilator and you just run the tube down, you're going to take out a core biopsy of the entire disc, which you don't want to do. It's not what we're here for. All right, I'm ready. So at this point, Luis is going to hand me this guy, and I think the lateral is fine. Let's get a blue towel in here. Just going, yeah, give it to me. I'll set it up. Okay, we're going to put it right here. Hopefully it'll help us divert the liquid away from my shoes. Yeah. So we have some strategies we've developed over the years to help reduce the feeling of coldness in my toes as I do the surgery. All right. So I'm going to reset this real quick, because yeah. No, it's fine. I want to bring it all to this side and put this back on. All right, so there's an old saying, the show must go on, right?
Always.
All right, very good. So we've got the endoscope set up, and we're ready to go in for our first disc and take a look. I'm going to turn the irrigation on. Good. All right, it's a little overexposed, so let's turn the light down. I've got the pedal to my foot. Good. One more down. Perfect. All right. So what we can see down here are fragments of disc herniation. Yeah, thanks. Now, for those of you who are die-hard Deuk spine fans and you like watching all these surgeries, I'm talking to you right now. You may have noticed that not all the endoscopic views are the same. You may have noticed that with some surgeries, we actually have a better view, right? And you'd be correct about that. And the reason is that the cervical scope that I use, that's a herniation, by the way, down there. It's kind of... The cervical scope that I'm using is a fiber optic scope. It's not a rod lens scope. So, watch this, please. Did it hit me? Yeah, just, yeah, keep it over. I don't use that as much, Luis, for the cervical. I don't have to twist it like I do for lumbar. So just keep an eye on it. Man, she's relaxed, right? She's really clamping down on this tube. So anyway, for the die-hard fans out there that watch our surgeries all the time, you know who you are. Wow. The reason that the lumbar surgeries have a better view is that they're a rod lens scope. I still think we're overexposed. Yes, thank you. Wow. I'm trying to loosen it up just a little bit. That's incredible. How tight she's clamping down on the tubular retractor. So one of the things you're going to see as we move along here is there's a lot of scar tissue right here where the herniation is. Remember, herniated discs, they actually promote scar tissue. They actually cause inflammation. And that inflammation causes scar tissue. Yeah, anytime your body has inflammation, you're going to have, watch it, you're going to have some scar tissue. So you really want procedures that reduce scar tissue to the minimum. You don't want a lot of scar tissue in your body. Scar tissue is not good. It's inevitable. It's definitely going to be part of everything you do with surgery, for example. There's always scar tissue. But you want to do some surgery that's going to minimize your scar tissue. And the Deuk laser disc repair you're watching right now produces the least amount of scar tissue of all surgeries for herniated discs. There is no surgery that produces less scar tissue. That being said, the herniated disc itself produces scar tissue. And that's what I'm dealing with now, right here. And just so you know, if you notice when I first went in, I could not move the tube at all. And by removing the scar tissue here, by the way, you know, when people have a disc injury, they really lose a lot of movement to their neck. People who have had disc injuries are probably saying, yep, you're right, Dr. Deuk. Certainly do. And it's true, they lose movement. Their necks get stiffer. And guess why? They get stiffer because of scar tissue. So as we remove the scar tissue in this patient's spine from where the herniations are, you're going to actually see that it's easier for me to move this tube. Okay? Already it's gotten a little bit easier. Any way we can find out how our lumbar fusion's doing? I know that he was having some pain.
I sent Mike to do that.
I was thinking maybe some dilaudid.
You gave me some dilaudid.
Good. Okay, thank you. See the movement already we're getting? It's not a lot, but it's definitely more than it was just a few minutes ago when we got started. Look at that herniation right there. See how scarred in it is, all white? And then the golden color is calcium, calcification. So, yeah. Yeah, she's had these hernias for a while. I don't know the exact amount of time, but when you look at the MRI, you can see they've been there for a while. Yeah. At least several years. But you know, the truth is with herniated discs, it's not like it's one event that happens usually. Most patients, most people with herniated discs, it's several injuries. So the first injury may be is definitely the tearing of the annulus, right? You have to tear an annulus to have a herniated disc. That's 100%, without a doubt. There are some cases of where they'll have a fracture of the bone and they'll get a herniated disc, but 99.999% of the time, rounded up to 100, there's going to be an annular tear. That is the first thing that happens. So there's some traumatic event where they tear their annulus. You know, maybe it's a potato sack race when they were 13. I don't know. Yeah, and that annular tear may not have an associated herniation. It may just be a tear. Irrigation-wise, how are we doing? Because I'm getting bubbles. No, there's none even coming out here. I'm getting no irrigation here. Sorry, my bad. The wire actually pushed it closed. So, interesting. Yeah, so these cervical lasers are interesting because your endoscope is right up against the patient's chest, usually, and sometimes their body will turn off things it's not supposed to turn off. But I didn't design the actual camera itself or scope itself. I just have to use it. So anyway, what I was trying to say earlier is that herniated discs, when you see a herniated disc, it's usually a stepwise progressive issue that people deal with. And so the initial injury has to be an annular tear. It could be an annular tear and a herniation, but it has to at least be an annular tear. Okay, after that, you're going to get the jelly pushing out through the tear. We call that jelly the nucleus pulposus. Okay, and it pushes out through the annular tear. It is? The irrigation's going on the floor? Yeah. So what's happening is it's probably going here. Yeah, these necks are hard to do, Luis. But it's not the end of the world, Luis. I need the laser on, please. All right, so I'm going to pull this back a little bit. This is all scar tissue, calcified scar tissue. This is going out into the right foramen. Are you asking me?
Yes, sir.
Yeah, we're starting to get lateral here. That's correct. This is just the gobbed up herniation right here. Actually, I should clarify. This part of the herniation, it has a name. It's called an interposed herniation. It's the part of the herniation that's actually located within the annular tear. So I'm actually doing mostly annular debridement right now. And what I'm debriding is the scarred up annulus, but also the herniated disc that's stuck and wedged in into the annular tear.
We have a question.
Hold on, I got a question in the OR. What was the OR question first? No, it's called an annular tear. It's for the annulus fibrosus. The disc has two parts. It has an outer annulus fibrosus and it has an inner nucleus pulposus. It's the herniation refers to the nucleus pulposus leaving the center of the disc going out through a tear. So that's what we're really talking about. All right, Zach, what's your question?
We have a viewer who says, I've already had 2 new discs put in.
Artificial.
I believe so.
Okay.
They said, now after 2 years, I'm still in pain, but they want to go back and put 2 more in. I'm scared to die, and I'm not sure what to do.
Yeah, you should be scared, okay? So this is a person who's watching and they're asking me, Dr. Deuk, help me. I don't know what to do because I already had 2 artificial discs put in. I'm still having problems. They want to do 2 more. What should I do? Don't do it. I mean, 4 artificial discs, it's crazy, right? To me, it's crazy. I would never do that. You need to see me. You need to get here to Florida and see me so I can help you. And the first thing I'm going to do, just so you know, is I'm going to figure out like why you're having the problems you're having. Are you having, is this in the neck or the back? I don't know. But let's say it's in your neck. Are you having neck pain? And is that pain due to your facet joints? If it's the facet joints, then we're not going to do any surgery. We're going to fix it with a needle. Go in and kill the pain nerves to the facet joints. That's the standard treatment. It's safe, very effective, doesn't involve surgery. It's wonderful. On the other hand, if it's a herniated disc that's causing your problem, whether it's your neck or your back, we're going to fix the herniated disc. We could do it with a laser. There's no reason to have more artificial discs put in. I don't even put artificial discs in, folks. I don't believe in them. I think that the technology is hyped up. That's my opinion. Have I put them in before? Absolutely. And my personal opinion, my professional opinion, is that I would never put one in anybody, especially not my family member, and I wouldn't put them in a patient. Okay? I treat my patients like family. I think, what would I do for my mother? What would I do for my wife? What would I do for my sister? And that's what I do for my patients. So I would never put an artificial disc in any of my family members. Okay? There's reasons for it. You all don't know what I know about artificial discs. I'm going to tell you a story, since I probably don't have another question for a little while. All right.
Patient doing better. He's gonna get on a chair now.
All right, good. Did he get oral dilated? Do you know? Oral?
Yeah, he got.
Oh, good. Thank you. So I'm going to tell you a story, okay? It's an interesting story, but something the public should know is that doctors do what's called continuing medical education. And what that means is once we graduate our training programs, we need to keep educating ourselves. So we stay on top of new things, and old things that we didn't learn before, we learn them. So we keep getting better and better at being doctors, right? Taking care of patients, with the idea of providing better care that's less invasive, less costly, less risky, more effective. That's the goal of being a good doctor. You want to give your patients the best you can. Okay? So to do that, you have to have knowledge. Knowledge. Some knowledge comes with experience. Other knowledge comes with, going to meetings. So a meeting that I used to go to, which was my absolute favorite meeting because it's special, was a meeting that we used to have in Whistler, where all the spine surgeons would go, probably really about 50% of them. And this meeting was special because the guy who put the meeting on, he's a old neurosurgeon, Dr. Cahill, okay? And he's famous. If you ask any spine surgeon around the United States if they know who Dr. Cahill is, they'll tell you, yes, he's famous. He's a very, very good neurosurgeon that specialized in spine. Now, every neurosurgery meeting I've ever gone to, the neurosurgeons go and they all dress up in suits, okay? Suits and ties. Doesn't matter where the meeting is. It could be in Miami in the middle of summer, and they're all going to be wearing suits and ties, okay? But not with Dr. Cahill's meeting. Not his meeting. A meeting was in a really nice place. We were very lucky. It was outside of Vancouver, in a place called Whistler. And I personally love snowboarding. So I would go to the meeting, but not to snowboard. I would go to the meeting because the way Dr. Cahill ran the meeting was very different than every other meeting. You see, every spine meeting out there, every neurosurgery meeting out there that I know of, they try to get the companies that sell things like artificial discs, screws, rods, to pay a lot of money to be at the meeting so that they could showcase their products to the surgeons. And Dr. Cahill was no different. He would make the companies pay to come to the meeting and sponsor it. So the companies would come and they would always try to sell their implants to the surgeons, and the surgeons got an opportunity to see the newest implants. So it kind of worked out. But what was unique and different about Dr. Cahill's meeting is that he would actually allow an open dialogue to occur during the meeting. And what does that mean? What it means is the dialogue of every meeting is tightly controlled by the meeting organizers. What does that mean? It means that you really can't say anything bad about the sponsors. if you're a doctor. You couldn't say anything bad about them in front of everybody because they wouldn't give you the opportunity to do that. But at Dr. Cahill's meeting, this guy would show up in cowboy boots and a cowboy hat and a cowboy vest. He was a real cowboy. And he was just very open and honest, and he would allow the surgeons to bring up issues that maybe they were having with a company's product. So he would allow surgeons that had problems, for example, with a particular product, they would allow them to talk during the meeting in front of 1,000 or 2,000 surgeons that were attending. Well, this really bothers the implant companies, the Medtronics of the world, the Deus of the world, because basically somebody is going to badmouth their product from their experience in front of thousands of surgeons, and they don't want people hearing the bad stuff. They only want people to hear the good stuff about their products. But of course, Dr. Cahill didn't care what they wanted. Dr. Cahill wanted the truth, and he would let the truth come out. And it wasn't long, it was a few years of bad-mouthing the artificial disc products when the company stopped supporting the meeting, and of course the meeting went away and died. Because without the support of these big companies, you can't have an expensive meeting like that happen. So the Cahill Spine meeting that used to happen every year went away and died off because there was no industry support. Just to give you an idea, you know, to put on a meeting like that, it costs literally millions of dollars, and without financial support from anyone, it's impossible to have such a meeting, right? So I decided to take what Dr. Cahill did and to go a little further. So I produced these videos of spine surgery where we not only show you the actual surgery happening in real time, but we get to talk about issues that are happening in spine. And anyway, at Dr. Cahill's meetings, you could count on surgeons. They would show up and they would like literally talk about all the complications that they had with artificial discs. And I mean, popping out of patients' backs, out of their necks. And the complications were horrendous, but of course nobody knew about them because they were kept secret until that meeting where they started talking about them. And then everybody became aware of the complications. So I guess what I'm trying to tell you in a long-winded explanation is that there are very powerful forces, businesses, that want to sell those implants, and they will not tell you all the truth about them. And I think that's wrong. There's a fragment. We got to get it out. So the truth is, I've heard about way too many complications with artificial discs from my colleagues who've had a lot of experience, and their reports have been, let's just say, quieted over the years, hidden, kind of like electric car technology was hidden for 60 years by General Motors to avoid having electric cars so they could keep producing cars with combustion engines. And I don't believe that's right. I don't believe personally in hiding the truth from people. I think if you have product that's really good, then let the truth be known. If you have a product that has a problem, then let's address those problems. Unfortunately, the artificial discs, for those of you who don't know this, the technology was developed by these companies in the United States that did all the testing, right? They were available in Europe long before they were available in the States. And these companies that did all the testing and got FDA approval, they then sold their technology to the big distributing companies like Medtronic and Deuk and Synthes. They sold it for literally hundreds of millions of dollars. That's the right to produce these products after they got FDA approval. So these companies have spent quite literally 4, 5, 600 million, to this point $1 billion, in buying the technology and marketing it. So they want to sell these artificial discs because they want a return on their investment. They have stockholders and boards that have to be reported to. Well, I don't have a stockholder and a board that I have to report to. I have the public. I have my patients that I am beholden to. So I'm all about sharing the truth. Trust me, if artificial discs were great, I'd be doing them. But I don't. I don't do them. I'd probably make a lot more money doing artificial discs. But I do these surgeries because they're better. So I don't know if that answers your question in a long way, but I certainly entertained myself for a little while. Take.
Good story. Good story.
Yeah. That meeting was amazing. But I thought there's no way this is going to last. I've never seen so many people complaining about things and just getting away with it. So,
We have another question.
yeah, sure.
We have a viewer asking, why would a surgeon prescribe 50,000 IU of vitamin D2 and 950 mg of calcitrate for a neck fusion before any blood tests were done?
So why would a surgeon prescribe 50,000 international units of, I think, vitamin D, right?
Vitamin D2.
Yeah. And calcium before any tests were done? I think I can answer that. I can't speak for that surgeon completely, but I can tell you that a lot of surgeons worry about patients fusing properly. So, you know, fusion requires calcium. It requires vitamin D. It requires that you have normal levels, you know, normal bone metabolism. I think the surgeon was just trying to make sure that, you know, they put the surgery in your favor. Let's just say it's you. I don't know if it's you or not. But basically, they really want to make sure you fuse. But honestly, I don't know that that's going to help in any way. I have never done that myself. And I personally don't believe that that's going to make a difference. I could be wrong. But I don't think that it's not going to make necessarily a positive impact, but it could help. On the other hand, I don't really think it's going to hurt in a negative way. I don't think it's going to hurt you to take the vitamin D and the calcium. I really don't think it's going to hurt. So I think you're probably okay doing it. I just don't know that there's really a benefit to it. Stand by. So I don't think it's necessarily a bad move. I just don't do it myself.
We have another question.
Yeah. Okay, medicine.
We have a viewer who says, I have a herniated disc in my neck, C4, C5, compressed against a nerve, narrowing of my spine, tingling and numbness down my right arm, especially when I sit up, constant nerve pain in the back of my neck and right arm, and also weakness, and they're wondering what they should do.
All right, so we have a person who has neck pain, arm numbness. They probably have a pinched nerve. What you should do is get an MRI of your neck if you don't already have one. Probably a nerve test of that arm that's numb. Yeah, I'm ready. And then come see me, you know, or just get everything done here. It's the dye in the water. Shot. It's still on this side, but it's all the contrast dye. Okay, shot. That's better. Okie dokie. So, yeah, you need a diagnostic, some diagnostic imaging, MRI, nerve test. You're gonna need probably at least an epidural if you haven't had one. Okay, you got to pull it straight out. Yeah. So a shot into the spine is what I'm thinking. All right, we're gonna head south. Let's shot. Okay, I'm gonna come out and go south. Shot. And I'm gonna want to check my AP in a minute. Shot. So let's go AP, Coker. You know, I would say if you've done the epidural, or if you've not, you don't have to do an epidural shot, but you got a pinched nerve. You're probably going to end up needing surgery, to be quite honest with you. It's just hard to say for sure. I would really like to see your MRI and your nerve test. Shot. Yeah, lateral. If I could see your MRI and your nerve test, I could tell you what we need to do. We do free MRI reviews at Deuk Spine, just so you know. Be happy to do one for you. Shot. That looked good. 2, 3, 4, 5, 6, 7. So I got an angle, rocket, bite it, shot. All right, Luis, mallet. Shot. That's good. Coker AP. Just let me know when you're ready. It's a quick AP. We just want to make sure we're midline. 2, 3, 4, 5, 6, 7. Yeah, that's good. All right, lateral. Take this. Give me the mallet. Shot. And pipe cleaner. I think we're in the disc. That's it? Perfect. We're going to do another discogram. You know, if I really was advising you, look, I'd tell you to come here to Deuk Spine. I'm going to tell you something, Shot. I have people come from all over the world here for treatment for a reason. We really are the best in the world at curing back and neck pain and arm and leg pain. Shot. And I even have, can you pull the shoulders, please? I even have, no, you pull the shoulders. Both sides. Reach around, grab the balls and pull down. Don't put your hands up there. Grab the side. Here, let go. Right here. Push in, and it'll come down. Shot. That's perfect. So stay there for a second. So what I was going to tell you is, Shot, is that my family members actually fly from California, wherever they are, usually California. That's where most of them are. It's perfect. You can see the leak, the tear in the back. Go ahead and relax. 2, 3, 4, 5, 6. They come here and they get their care here. Why? Because they trust us. Okay? I recommend they come here. No, I don't want an AP. I want a lateral. Mallet, it's okay. Yeah, I needed Luis to pull one more time in just a minute. I knew I shouldn't have worn my brand new sneakers today. I feel like I went in the pool with them. Yep. Shot? It's okay. We'll get it, Luis. I'm not worried. It's just that I wear expensive sneakers. Okay, good. That's all I wear, you know, is sneakers, nothing else. I wear my sneakers with a suit. That's correct. I was telling you about the story about neurosurgery conferences, right? The American Association of Neurological Surgeons, the Congress of Neurosurgeons. You go there and literally everybody's wearing a suit. a tie. So about 12 years ago, I started going with a Hawaiian shirt. And my wife, she was like, "What are you doing?" I'm like, "I don't care, to be honest with you. I'm so sick and tired of these pretentious snobs. They don't give a shit about real medicine. All they care about is their image and how they look on paper. And I'm sick of it. I don't want to have anything to do with them." True story. Show me the good science. Show me that you're making life better for people. That's what I care about. Not dressing up in a suit. So yeah, I have never gone in a suit unless I'm giving a talk. If I'm giving a talk, which has been a little more often lately, I'll wear a suit. But otherwise, the funny thing is that now people are starting to wear more casual clothing to these meetings, you know? You're there all day. And like literally, I've been to one in Miami a couple of years ago where it was 95 degrees outside and people are walking around in wool suits. It's like, are you crazy? Really? Oh. Anyway.
So about the look, not the size.
Yeah. And the way they talk to you, the way they look at you, the way they talk to you, they're not human. They're something else, right? Really. And I've never been able to identify with them. The only thing I've shared with them is a love for the nervous system and fixing it. All right. Let's see. I got a little tango going. A little tango and cash. Luis, you're the man. The man with the solution.
We have
Viva la raza.
a question.
You like that? All right. Yes, I'll take the question.
We have a viewer asking, after a cervical discectomy, cord compression C345 infusion 1 week ago, is it normal to have the same pinched nerve feeling on the main side into the shoulder blade and arm as before the surgery?
First of all, thank you for being here. Very nice to meet you. I have to be careful what I say to you. Your question, I'm going to try to answer it delicately, okay? The answer is it normal? If you're my patient and I just did your ACDF, 100% no, it's abnormal. I would be very concerned right now that I didn't do my job right. But is it normal for other surgeons? Yes. I see it all the time. And I don't mean that like to make light of your situation. I promise you I don't. I just have to tell you the truth. The truth is, I don't know who did your surgery. I really don't want to know. You don't have to mention a name. But it's not normal to have the same symptoms after the surgery that you had before. At least not in my patients and not when it's done, you know, when things go well. So I can't tell you why you have those problems still. I mean, there's a list as long as my arm of possibilities. One is that, you know, and I hate to say this, we were talking about earlier, but did they do the right level? You know, if you had a herniated disc at 5'6", did they do 5'6", or did they accidentally do number 4'5"? It happens. Believe it or not, it happens. And it shouldn't happen, but it does happen. So I don't know if that's the case. Scope off, standby laser. Or if that's not the case, did the surgeon just not get enough of that herniation out in the back off? That is so common that happens. I can't even begin to tell you. Why? The truth is that you probably had your surgery at a hospital, I would imagine, or an ASC, and a lot of times the surgeon doesn't know how to use a microscope or an endoscope, and so they won't use it during surgery. So they're actually, can somebody pinch my tape on the bridge of my nose? It's just coming off and the air is coming up and tickling my eyeball. Yeah, right there. Thank you. Yeah. Yeah. So happens all the time where the surgeon goes in and doesn't actually unpinch the nerve. They just do a fusion. Horrible, horrible, horrible. It's given, okay, laser. It's given such a bad reputation to surgery when they do that. It's the wrong thing to do. And why would they ever do it? It saves time, number one, by not taking all the herniation out. And number two, it reduces the risk of complication for them, which, by the way, you know, coming out of surgery with the same arm pain that you had before is a complication, in my opinion, and most people's. So they're not really saving themselves from a complication by not adequately decompressing the nerve root. That's most likely the cause, to be honest with you, is that they just didn't do an adequate decompression. Let's get a shot on the scope. Fluoro shot. Go ahead. Okay. And shot. I can't see, Luis. All right, good. So if you're asking me why it happened, I can't tell you right now without more information. But I could tell you for sure if I saw you or if I saw your MRI or CAT scan. So if you want me to help you, I'd be happy to do it. We do free MRI review, free CAT scan review. I would say in another week, if you still have the same symptoms, you need to get an MRI and a CAT scan. There's two ways to do it. You can go back to your surgeon and say, I'm still having pain. Would you mind getting a CAT scan and MRI? I want to get a second opinion, or I just want you to look at it yourself and tell me what you see. But I can tell you right now, it's just not normal. Okay, it's not normal. I'm not going to lie to protect another surgeon. I'm here to help you, the public. And I'm telling you right now, it's not normal. Yeah. But I couldn't tell you why it's that way. Oh, look at that herniation. Do you see that come out? Just hit rewind and you'll see it come right out of the back of the disc and right into the disc space, basically. Pretty cool. There's another herniation that just came out. You see that? Those are all most likely what are called subligamentous herniations, meaning that they're right out the back there. Down there, that crack you can see is the end of the vertebral bodies. That's the end of the disc space. Down there, that's where the spinal cord is. So those herniations went out through that crack, and now they're starting to come back, which is good, because they're no longer pinching the nerve or the spinal cord. They're now, you know, on the floor or on the drapes.
We have a question.
Yes.
The person who asked the previous question is asking, is it possible that it may just be taking time before the pain will get better?
You know, it is possible that it's just taking time, but like you said, is it normal? In my experience, 100% no. If I had a patient like that, I would be concerned. That's just, you know, but it is possible. But it's unlikely. Yeah. I would not say there's a problem just yet. I need to see your films. I'm just telling you, based on the years and years of experience, getting to the back of the disc. You see the place I'm at right now? This is literally the back of the disc. This is the herniation. Getting back here, I'll tell you right now, orthopedic surgeons don't come back here because this is a neurosurgical zone. You basically are up against the spinal cord. So there's another herniation. They just keep coming out, which is good. So I'll give you an example. Right now, my mask is fogging up on me. All right, I'm wearing glasses and I'm getting a lot of fog. And the reason is that the tape that holds my mask against my skin is coming off. And it's not normal for that to happen, but it can happen. It's not normal, but it is a problem. And it's my fault. I just didn't put the tape on properly. I'm not blaming anyone else. Yeah, I just got, there's just a lot of moisture around. It's lifting the tape off of my skin. Huh?
You want to retap or
I don't know. I may have to retape. You want to grab another piece of that tape from outside? The point I'm trying to make is it's not normal for the tape to come off and for my mask to fog up, but it can happen if I don't do the tape properly. So I think that's my best way to explain it. Tell me when you're ready.
Beth is ready. And something to
Tell
keep
me.
the glasses, please.
Beth, are you ready? All right, give me a second. Let me just get this piece out. So what I'm doing is I'm floating these fragments out. These are pieces of herniation at the back of the disc there. And rather than going in and getting a pituitary, a lot of times I can just float them out because there's so much liquid going in with my irrigation that it'll lift them up and pull them out. Tell me when you're ready. All right, standby laser. All right, let's close that. Let me come to you. I would say take my glasses off first. You see them? Take them off. Get the tape off next. Probably need a blue towel. Do you have one, Luis? Let me have it. Thank you. So go ahead and take the tape off. Don't worry about peeling my skin off. It'll keep me out of the dermatologist's office for another month. Go ahead.
No charge for the dermabrasion.
Yeah. Throw it, or put it away or down on the floor. Something like that. There you go. I'm going to hand this to you. Don't grab where my hand is. Go underneath. Yep. And now go ahead and wipe the moisture off. Yeah.
Like that shit. Boop.
Yeah, good. And then go ahead and put another piece of tape. Higher. Get
Higher.
lots of skin. Squeeze hard. Yep. Oh, my eyeball. I'm just kidding. Push down hard on the skin. Yep. And now I'll take my glasses back. Phew. It's warm in here.
It is warm.
Right? What the hell is Sonny doing? Hey, Zach. Let Sonny know we need the room cooled.
Yes, sir.
Underneath, just above my ear, but under the hat. Right? Yeah, scrape against my skin. There you go. This side's stuck. A little higher. Great job. Thank you. Perfect. Nice job. You did surgery on my mask. All right. So, I don't know what else to tell you. I just think it's highly unusual that you still have the same symptoms that you had before surgery. I don't think it's normal. I really hope it goes away for your sake on its own. But like I said, if it's 2 weeks out, if you're 2 weeks out, which you're not, once you get to 2 weeks out, if you're still having problems, I would just talk to your surgeon and get some pictures done. And like I said, I'd be happy to look at them for you, kind of give you a second opinion about it. Zach, would you see what Sonny can do, if anything at all?
I just talked to him and he said it's set as cold as it can go right now.
All right. Fair enough. Huh? Summer's here, right? We do the best we can.
We have a question.
Yeah, I'll take the question.
We have a reviewer asking, can you repair and treat syringomyelia?
Can I repair and treat syringomyelia? Well, the answer is no. I cannot, but there is a treatment for it, yes. And the truth is that I would just end up sending you to a university hospital because I don't treat it. It's not a degenerative spine condition. It's what you need to do if you have syringomyelia, and honestly I don't know if you've had medical attention by a neurosurgeon or not, but I would strongly recommend you see a neurosurgeon for that. And there are some causes of syringomyelia that require immediate treatment. I don't know if you've seen anyone yet, so I would recommend you get into it and get seen in the next couple of weeks if you haven't. It can be a pretty serious condition. So it depends on what's causing it. There are sometimes tumors that are associated. There's tethered spinal cord, where the bottom of the spinal cord is kind of stuck down for various reasons. Again, I don't know your history, and I don't really need you to share it with me right now. All I know is that you need it evaluated by a neurosurgeon. Are we pumping the fluids in?
Yes, we're good.
So yeah, the syringomyelia is not something that I can treat with this laser. And to be perfectly honest with you, I'm just not the right person to manage that condition. I'm really good with herniated discs, spinal stenosis, pinched nerves, pinched spinal cord, things like that, degenerative conditions, trauma like work comp, work accidents, basically traumatic injuries to the spine that are not like life-threatening, but spinal stenosis, herniated discs. By the way, what we're seeing down there is the posterior ligament, and we're going out the foramen here, and you can see from the first discogram that was done that she's got pretty bad injuries to her discs. They're not trivial by any means, and she's a younger lady. She's just going to have problems her whole life with these herniations if she doesn't get them fixed. So I'm expecting them to be fixed after today, and for her no longer to have issues. As long as she does what she's supposed to, like with restrictions, she's going to do fantastic. She would have had an ACDF or anterior cervical discectomy infusion, would have been the alternative. She didn't want that. She's smart. She's like, I don't want metal in my neck. I don't want anything artificially put in there. Does anyone know why I would never have this procedure done that you're watching right now? You guys are too smart. Because there's nobody to do it. That's right. Quite literally, there's no one in the world that does this in the cervical spine besides me. And I can't operate on myself. I'm good, but I'm not that good. So all I can say is she's lucky she's got me to do this. All right. So again, I'm floating out the pieces of herniation, and we're just about done with this disc, and I'm just about ready to go and do the last one. It's funny. I know it's her right arm, that bothers her the most, but she's got pretty good sized herniations on the left side as well. Really substantial. All right, let's see. what I can do here. Oh yeah, look at them all coming out. That's the foramen on the right. And honestly, there's nothing in there. That's great. We'll just finish up here. And this is the left side. There's a big herniation there. Right there. Let me have standby laser. Let me have the grabber. And then we're gonna move on to our last disc. Yep. Our last disc herniation at the 4-5. A little bit of blood. We've probably lost 1 milliliter of blood at most. Stand by. Okay, let me have that. Grab her. Nice job, Luis. Take it. All right. So let's finish up here. Yep. I'll suck the. We're on standby on scope, please. And laser, both. There we go. I just want to make sure the scope gets turned off. Okay, dilator. So we've done 2 out of 3. I'm going to try to get the last disc here without actually having to make another incision, but we'll see. I'll do my best. So remember, with these cables, you never want to bend them acutely.
Correct.
Yeah, like that. It's almost too bent, but I don't know what to do. But you got to get the laser fiber down here. There you go. All right. Can you push my tape down again? It's on the right side only. That's the problem. Yeah. That's my left. That's it right there. I don't know why it keeps coming up. Okay, good. All right. So we're going to see if we can make our way up to the next disc that needs to be repaired safely, of course. So I'm coming out with our tubular retractor and take it straight out. There you go. Nice job. And this will be the last maneuver. So shot. All right. Yep. We want to put those right about here. We don't care about the clear tube. Shot. All right. Not yet. No. We don't need a shoulder pull because we're moving up the neck. So we're going to an area where there's no shoulder at all. Shot. Shot. I need an AP. Coker. And keep those wires away from me. Good. Just exactly where I showed you. Right here. Shot. That's it. Shot. Shot. That it right there? Huh. Shot. I need a lateral view. Is that neck rotated? Can you unrotate the neck, please? At least the cables are the least concern. I just need that neck straight. She derotated? Get that away from me. All right, so we got 2, 3, 4, 5, right? So we need to go up one. Shot. Shot. What?
6, 7, 4, 5.
What's the last one we did? Yes.
Let's go AP. I just leave them there. Don't mess with them. They stay literally right here. And they're perfect. All right. Shot. Shot. Almost looks rotated, right? What do you think? There we go. Shot. Shot. Perfect. Go lateral. Please don't hit my hand. You can't touch anything to my hand. All right, we are there. 2, 3, 4, 5. 2, 3, 4, 5. You agree? All right, I need to just make it move a little bit more north. Shot. That's perfect. I need an AP. Let me know when you're ready. These are right here. No. Luis, not that. It's the mallet. Alright. It looks like we're rotated a little bit. Wouldn't you agree? I think I'm close enough. I just want to move it just a millimeter to me. Right there. Wait. Shot. Yeah, that's perfect. Lateral. Take this. Lateral. I need you to stabilize the neck but not move it. Just hold it in your hand so it doesn't move. Let me make sure I'm in the midline. I'm looking good there. Shot. Yeah, that's really nice. Shot. Raytech. All right. Neck is still supple. All right, we're good. Let's go AP. Are you off the neck now? Yeah. Good. I don't need this. You see how it's staying? I do need the pipe cleaner. All right. Good. Lateral. Well, we were lucky we were able to do everything through one incision. And that's typically what I find in the young people with supple necks, is you can usually get everything done with one incision. Shot. Shot. Perfect. Now let's do a discogram. So far on our discograms for the other two levels, we have found that there is indeed annular tears. We found herniations. Shot. Shot. Not able to get anything out. Take. I need that guide wire back. Shot. There's some blockage. See if it works now. Shot. Perfect. You can see the annular tear right there. Give me an AP. So there was just a little schmutz in there from when I put it in. Came out nicely. Yeah, you can see the spine is somewhat rotated with scoliosis. We're not fixing, that's nice. You can see the dye going out both foramen, but worse on the right. You see that? So for those of you looking, if you look where the tip of the metal tube is, there's black dye running out to the right side. You can see it in the foramen on the right around the nerve root. I think this disc is going to be the one that's causing most of her symptoms in her right arm. So that's my suspicion. I need to advance this first. Side view shot. I need to advance this into the foramen, or towards the back of the disc at least. That's good. And I'm going to bring this guy down. I need something. See how sticky my gloves are from the dye? So I just squirt something over here. If you have water. Shot. If you don't, it's alright. Is that it right there? Yeah, nice. Alright, now we'll take that big tube. Yeah. Good, good, good. The impactor tube. Good. Mallet. 4x4. Yes, what's the question?
We have a viewer asking, is it safe to
Sure.
leave a collapsed disc at L3, L4 if it is pressing on the spinal cord?
Is it safe to leave a collapsed disc at L3-4 if it's pressing on the spinal cord? So, it's an interesting question. The only reason I say that is because there is no spinal cord at L3-4. The spinal cord ends on much higher at L1, L2. So there is no spinal cord at L3-4. So I don't know if you're talking about a spinal cord or a nerve root. I'll assume for a moment you're talking about a nerve root. Shot? Is it safe to leave it herniated disc against a nerve root? Most of the time, yes, it is. Shot? But if you're having symptoms from a herniated disc pinching a nerve root, you want to get it fixed pretty soon, especially if there's weakness. Weakness is not a good thing. If you're getting like you can't lift your foot up or something, leg weakness, then that would be an indication of moving forward with surgery quicker. If you're just having pain down your leg, kind of into your thigh area, if you're just having back pain or leg pain or even tingling or numbness, you can probably wait a little while. But once you get weakness, you want to get that thing fixed pretty quick. So I don't know if I answered your question. I think you meant L3-4, but I don't know if you meant C3-4. Because C3-4, there is a spinal cord in your neck at C3-4, but I don't know if you meant C3-4 or L3-4. So if your herniated disc is in your neck at C3-4, then you definitely want to get that fixed quickly. If it's on your spinal cord and you're maybe going paralyzed from it, you want to get that fixed right away. I hope that answers the question. So this is our last disc that we're fixing. It's the number 4-5. Woo, Betsy. Look at that herniation that just popped out. Hold on. Grab her. Try to get it out with a grabber. It's too big to take out with a laser. A lot of people ask me about the laser. They don't understand what it does, but basically the laser just delivers a pulse of energy right to where the tip of the fiber is, and that energy pulse causes a disruption of tissue. Basically, it causes the tissue to break apart into pieces, and the more dense the tissue is, the harder the tissue is, the more energy it takes. So it takes more than just one pulse, it'll take multiple pulses. So I don't know if you know this, but lasers are actually used to break up kidney stones. There are a lot of urologists that use lasers to take out kidney stones. So yeah, lasers are really good at getting rid of hard things, calcium, also really scarred up tissue. We're using them in brain surgery now to get rid of tumors in the brain and to treat epilepsy. So lasers are definitely here to stay. People, huh? The future of medicine, right? Yep. So there's a lot of doctors who don't understand that. They want to say bad things about lasers, but the truth is, we use them, and they work. As long as you use them the right way. There's a herniation there that just came out from on the spinal cord. What I found is that the people that usually say bad things about lasers have never used one. You know? It's kind of like somebody saying, oh, Ferraris are horrible cars, and they've never had one, right? Or if somebody has an ice cream sundae and somebody else is upset, they're going to say ice cream sundaes are bad for you, right? It's just good old jealousy. But it's a shame because, you know, doctors are responsible for taking care of people and advising them. Problem is, sometimes doctors can be a little biased to what they can do, you know. Like I say, if all you have in your toolbox is a hammer, everything looks like a nail. Right? You want to fix everything with a hammer. Then later on you find out what a wrench is for. Ah, shoot. Think about how much better that would have been opening that valve with a wrench, not a hammer. Right? Right, Luis?
And every laser is different. There's different types of lasers as well.
Uh-huh.
They're all different lasers react differently depending on their tissue.
Now they all have different properties, right?
Yeah, right.
CO2 lasers and argon.
Depth of penetration.
Is that right? Well, hey, there you go. I got an education today.
So the CO2 depth of penetration won't be as good as ammonium because depending on where you use it in the body.
Yeah. So what's the depth of penetration for CO2 laser?
CO2 laser is mainly used in air oxygen.
Uh-huh.
Versus like in fluid because CO2, ammonium is attracted to the fluid, to liquid, so
Uh-huh.
it dissipates a lot faster, so it doesn't cause damage to the surrounding tissue.
Right.
Whatever you touch with it is what you basically burn on or vaporize. So the CO2, you can set it to
10 minutes.
10 minutes?
Yeah. Very cool. Which do you prefer?
It just depends on
On the application?
depending on where we're working on my
What's your favorite laser to work with as a technician?
work with would be the Holmium,
The one we're using now? Why is that?
it seems to be the most tissue friendly.
Yeah.
It works well both plain air and underwater.
Uh-huh. Who else uses the Homium laser?
Holmium has very multiple uses. You can use the Holmium for tissue like discs. You can use
Yeah.
it for stones in the kidneys.
Yeah.
You can use it for also for prostate. You can use it on the skin.
Uh-huh. Okay.
This is more versatile, more tissue friendly.
So urologists like to use it for the prostate as well?
No, they prefer
The green laser.
the green light laser for the prostate, which is a KTP.
KTP?
KTP radiation therapy lighting. This is another element,
Mm-hmm.
and that's the favorite for the urologist for the prostate. There's another laser called the Boolean that's very similar to the Holmium,
Yeah.
but it's a continuous energy.
Like, zzz, there's no pulsing.
There's no pulsing, right?
Wow. Who uses it?
It's not used very common in Florida. It's used
What's
by
that?
Northeast.
Uh-huh.
Recently been introduced here in the U.S.
Who uses it?
We use it over at some of the urologists use it.
For prostate?
Mostly like bladder neck because they're really good for incision, like a bladder neck contraction or
Like a visceral incision?
so
Yeah.
just think about like a rubber band and around and then use it to cut that rubber band through the lasting tissue.
Uh-huh. But it's a incision on an organ. You can't use it to make a skin incision.
Yes, you can use it for skin
Really?
because you can change the settings so that it doesn't charter the tissue.
That's amazing. Huh.
The thing about it is it coagulates at the same time as well, so you have less bleeding.
That's so cool.
That's why I think the lasers are for the future because
You guys have that laser available?
we have it available, correct?
Can I take it out for a test drive?
Of course. Again, you gotta make sure it's available for the day that you want it. Doesn't have to reserve. Be available.
Well, I got to tell you, the patient's right side at this disc over there is not letting me go over there. So I really think the tear is pretty much more localized to her I should say her left side will not let me go over there. It's really more or less the right side, you know, where I'm able to go from the tear. And that's kind of what we were seeing, right? On her her discogram. We saw that the tear on the right side let the dye out around the right nerve root. Well, this is pretty much it. I mean, I'm done. This is the foramen right here. There's really nothing left in here. We've gotten it all out. There may be a little nubbin right there. It's all scar tissue. That's it. You can see the fibers right there. Posterior ligament, dura. Yep, nerve roots in there. And feel like we've cleaned it out really good. Let's get these pieces of bone spur out. Yeah, pretty much done. I think she's going to be real happy when she heals up. So spinal cord in the middle, off to the side on the patient's right, out in the foramen. And you don't want to gild the lily. Any questions from our audience? How's our lumbar doing? Is he ready to go? Yep, done. That's it. Yeah, knowing when to end in these cases, it's one of those things that if you you don't end at the right time, you end up doing too much, you can create a complication. And that's not what we want to do. So I'm going to apply a little pressure. And remember, how many discs did we fix? That would have been a 3-level ACDF. Let's break this down. So hold on, you got to open this tube. So you push this down. That way you can get the laser fiber out. So I'm just going to apply pressure for a few minutes in case we have any venous bleeding. Now most of the pieces of herniation, about 80% of them, they just kind of float out and go down in the bag somewhere. We don't really try to keep them or trap them. It's just too hard to try to save those little bits and pieces. All right, Zach, you want to get a view of this incision?
Yes, sir.
Here's a piece of herniation right here, Luis. Right here. You want to save that?
Thank you.
All right, you ready, Zach? So we did the whole surgery right here through this tiny incision. See it? It's basically like a little puncture mark. It looks like a vampire tried to bite her that had only one tooth. Maybe he got into a bar fight. Somebody cracked him in the mouth, right? And broke his other tooth. So it's a one fang neck bite. So did you see that incision, Zach? I mean, you're talking about like 4 millimeter incision. So that's why people love the surgery, because once they're healed up, you know, you can't even see the incision. Now, had she had a fusion, her incision would be this long. Okay, it would have been this long. So just keep pressure for another 2 minutes all the way down.
Yes, sir.
About that hard.
Yes, sir.
Not on the carotid, but like right between. Let me show you. Like right here. Feel it?
I feel it, sir. Thank you, sir.
Good job, Luis. Training wheels have come off. You're still on the bike. You're still on the bike. All right. Good job, everybody. Thank you. I'm going to head over there and answer some questions, and then we're going to go see how our patient's doing. He's up and ready to go. Beautiful. So, Zach, just meet me in the recovery room. We'll end this stream and we'll just go say goodbye to our fusion.
All right.
Luis, what do you want me to do with the gloves?